Good evening, everyone, and welcome to the second part of the 14th Jaipur Surgical Tutorial Masterclass on carcinoma of the rectum. For those of you who are joining these masterclasses for the first time, Jaipur Surgical Tutorial is an online education portal that we started more than 3 years ago at the Mahatma Gandhi Medical College and Hospital, where I've been working after finishing my term at SGPGI Lucknow. And this online portal is managed by my colleague, Dr. Anand Nagar, who's an associate professor of HPB surgery.
Arun, Kumar, your slides are now coming.
Thank you, sir. Vinny, please keep the door open.
In between the sessions, I will give information to the students as to how you can join Jaipur Surgical Tutorial. It's very simple. You just have to send a WhatsApp message to Dr. Anand Nagar, and then he will add you onto the group, and you will keep receiving information about various activities. So our regular activity is on Saturday morning, 9 to 10 Indian time, when a student presents a case, sometimes an operative surgery session, which is discussed by the faculty. And from time to time, we have some special lectures by the faculty of JST. And then about 1 year ago, we started these master classes, which are once in a month. Now they are last Wednesday and Thursday of the month, 7 to 9 p.m. India time, where we pick up a theme and we get a panel of experts on that topic who make 3 presentations on day 1 and 3 on day 2. So usually we give about 15 to 20 minutes to the speaker, about 5 minutes to the moderators, and 10 minutes for the audience Q&A. I would request the moderators that if there are no Q&As on the chat,
then we will start the discussion.
Then yes, you generate the discussion.
I will generate the discussion. Yeah.
Although the time allotted is 30 minutes, so that we have last 30 minutes for open house, but feel free to extend any discussion to
No
more than
problem. No problem.
minutes. So, but we have a kind of a convention that we start at 7 and finish at 9. So with that, I would like to introduce the 2 moderators for today. Dr. Ramesh Ardhanari is my former colleague. We were together at the All India Institute of Medical Sciences during our post-graduation and senior residency. And he is now one of the senior GI surgeons of the country with special interest in colorectal and various other areas. And Utpal is my former fellow from SGPGI, who is currently at the AIIMS Patna. So with that, I would hand over to Ramesh and Utpal to moderate and start with the presentations.
So there is nothing much for me to say. I will straight away invite Arun so that we don't waste time to start. Arun is the from the SGMC in Trivandrum, and he's a surgical gastroenterology in HPV and liver transplant surgery and general surgery of GI surgical also. So he is going to tell us the definitions of what is an anti-resection, low anti-resection, ultra-low anti-resection, intersphincteric resection, APER and ELAPR. So over to you, Arun.
So only thing I would like to add, Arun again is my former fellow from SGPGI, and in addition to what Ramesh described, he is a robotic surgeon also.
Oh, he's a robotic surgeon. Okay. Your voice, you are muted.
Arun, you are muted. Please unmute yourself.
Good evening, respected teachers, the moderators, Ramesh sir, Dr. Utpal, and my beloved mentor, B.K. Kapoor sir. So today we will just discuss about the definitions of all these terminologies. Thanks to Dwarika Clinic as well, Dr. Avinash, for supporting this. Why this topic? See, there are so many issues. One is there should be some uniformity within an unit, within a surgical unit, regarding the treatment and terminology of all these cancers and what we do with it. And among different units, there should be some consensus because we are talking the same, apple versus apple, oranges versus oranges. And this uniformity of terminology and staging will give the best treatment plan for the given patient. And it shows us a better communication skill, communications within the unit, and better documentation, naturally reflects into better outcome for the patient and will have a good quality publications. So in a way, it is one of the most important thing. But we define anatomy, somehow tumors may not follow anatomy always. So definitely, but still we need to learn something about the basic anatomy, and we will try to do some clinical, I mean, with radiology and intraoperative correlation. Finally, what should we call this surgery at the end of the day? And finally, to sum up a few points. So this is just an anatomy book.
Can you maximize your slides? The
Yes, sir.
size, so that it fills the whole screen, because here difficult to read.
Sir, it's filling the whole screen in my laptop.
Oh, but here what we are having is, I am getting two images, you on the left side and this on the right side.
On the Zoom, go to the right upper corner view.
For whom? For everybody?
No, for Arun.
Arun. Okay.
Yeah, I'm also getting half screen Arun and half screen his slide. In the Zoom window, Arun, go to the right upper corner. Do you see the view?
Magnify. You just press that magnifying glass. Maybe that will enlarge it.
No.
No, or that will only give a magnifying glass. I don't know. View is there. Now you can see the view is there in that. Can you go to that view?
It's the Zoom function actually.
It's on the Zoom. There's a view. Now I can see the view. You are not able to see the view? Is there no view? Is there? In the previous slide was clearly seen. Go to the previous slide.
Yes, sir. View.
Yeah. Press view.
Press view.
And full screen.
Standard mode.
Full screen. Sir, right now better?
No. No change. Because this arterial anatomy has been shown clearly, it should be full screen.
Yeah, we need to see the full screen. On the view, did you click on the standard view? There is a drop-down menu on view.
On YouTube, it's coming as a full screen.
On the drop-down menu, in the view, there is speaker.
Yeah,
No,
so select standard.
You choose just standard.
Speaker, gallery, multi-speaker.
No, above speaker, you will see standard.
Sir, standard is not coming.
Okay. Then you go to side-by-side gallery. Maybe that will work.
Gallery.
Click on that.
On the left-hand corner, you have three buttons. One to close the screen. Then there's a green button. I think the green button will enlarge the screen. You can see that on the left-hand corner, right at the top, above home. Yeah, there's a green button. No, just see what happens when you press the green button.
Sir, right now it is okay?
No, it is still half screen.
No, but Ramesh, that is for the point.
That's a full screen. No, that is to make it full screen. I can see the two arrows. The green button. You can see the green button there. On the left-hand top.
Beside your yellow button. Yes.
Yeah, just press that and see enter full screen.
No, but that is the PowerPoint function. We want to change the
on
Zoom
YouTube, it is coming as full screen.
Right now?
No, it is not full screen.
It is giving us half and half.
But on the YouTube screening, it is coming as full screen, sir.
Yeah, YouTube, but not here.
Yes.
It's not coming here. On the PC, it is not coming.
Okay. So all of us are seeing half and half?
Yes, sir.
Maybe Arun, stop sharing and share again.
Okay.
Yeah, maybe it will work then. Hello.
Share again. Okay, if you share again, we will try to go to YouTube. It is showing YouTube on my PC, so I can open that and then maybe I'll get a full screen. So just share again. And even if it comes half screen, let me open that YouTube function. Arun, you're muted.
Arun, unmute yourself.
Yeah.
Okay.
Okay, now open the share screen and see if you'll get that. Yeah, we have got a full screen now. Yes.
Right now, okay, sir?
Yes, it is okay. It's perfect.
Okay. I'm sorry for that.
You start
No
from the
problem, no
beginning.
problem. You just start from the beginning again.
Yeah,
Go
start
back
from
to
the
the,
beginning.
if you want to go back to the first slide. Yeah.
So basically, see, this is a thing. The thing we would like, our surgeons, we would like to understand is, we can forget about all the anatomy regarding this rectum except for this opening.
Others, please mute yourself.
Except this opening. This is a hiatus for the rectum.
Except,
So just except this opening, which is very important, that's a hiatus for the rectum. That is a anorectal junction. So one important anatomical landmark we would like to highlight is anorectal junction, and which is the border of which will be the puborectalis muscle, which is an important function, which imparts an important function for continence. So the yellow one is the puborectalis, and the green one is the pubococcygeus, and the violet one is the ileococcygeus. These three actually constitutes the levae trainae. So whenever we do a laparoscopic anti-resection or low anti-resection, whether it is laparoscopic, open, minimal access, robo, whatever, so the entire thing we will be seeing as levae trainae muscles on both sides. So the convergence of this levae trainae muscle to the rectal tube is the junction between surgical anal canal and rectum. So that's a anorectal junction. So that's the importance of this imaging. And there is one important terminology the radiologists always tell is sigmoid takeoff. They mentioned it in 2019 consensus guidelines, their meetings. Basically, this is to distinguish rectum from sigmoid. That means to identify the rectosigmoid junction on a sagittal section of an axial imaging. The sagittal section of an imaging, usually it's an MRI, sometimes a contrast CT. So the rectum will be straight, at least in this part, and it will be seen throughout in the sagittal image, except when it turns horizontally, that means a sigmoid takeoff. So that is a junction between sigmoid and rectum. We have seen the junction between rectum and anal canal. So these anatomical landmarks are very clear from the preoperative imaging side. And one important point is lower border of the tumor, especially if it is palpable on the digital rectal examination, is an important criteria for treatment planning, not for the terminology of the surgery. So clear. Again, this is the lower rectum, mid rectum, high rectum, and the sigmoid takeoff. And the lower rectum is practically only 2 to 3 centimeters. That's what we will be getting. Because this anorectal junction, the anal canal is 4 centimeters nearly. And almost always they draw a line between, the radiologists draw a line between tip of coccyx to the lower or upper, sometimes upper border of pubic symphysis. Lower is better. So whatever it's below is anal canal, above is rectum. So here, this is a sigmoid takeoff. this is a rectum and this is a anal canal. This is a line from tip of coccyx to lower border of pubic symphysis. So how to differentiate, further subclassify lower, mid and upper rectum? The lower 4 centimeter we know. 2 to 3 centimeter above that is the lower rectum, and mid rectum is still the anterior peritoneal reflection. So another important thing, just like sigmoid takeoff is anterior peritoneal reflection, still that is mid. Between anterior peritoneal reflection and sigmoid takeoff is upper rectum. Something extra and more detailed about intersphincteric resection. So just only one picture is required to understand this. This is the smooth muscle of the rectum, and this is the internal anal sphincter. This is the external internal sphincter, which will be continued with levator ani muscle. We need to see only 3 things here. This is the green line. That means the anastomotic line is going to fall at the dentate line. That means it's a partial intersphincteric resection. And this is the anal verge. We know where the anoderm meets the perianal skin. There will be some change in color in most of the patients. So this 2 centimeter area from the dentate line, this is the anoderm and this is the perianal skin. So somewhere in between is subtotal intersphincteric resection. And whenever we resect the rectum and include the anal canal along with the internal anal sphincter till the junction of anoderm and perianal skin, we call it as a total intersphincteric resection. So by definition, ISR is a TME with excision of varying length of internal anal sphincter. So only 2 important things, dentate line, and anal verge. So all these points we know now. We don't need to, learn further regarding the level of all these anatomical points. But before jumping into the anterior resection, first, let us just see what is a sigmoidectomy. It's very rarely done. Usually the lesion is at the apex of a very large redundant sigmoid. The difference between anterior resection is the superior rectal artery continuing as the IMA above is preserved actually. So the rectum is, the distal stump is actually dependent on the superior rectal artery, which is in continuity with the inferior mesoteric. Then lap mobilization is done, sigmoid vessels are taken, and probably the ascending branch of left colic is also taken, and an intracorporeal or extracorporeal anastomosis is done. Then only we can call it as practically sigmoidectomy. It's not common. It's a very rare surgery. The anatomical, the anatomy should be very much favorable. So by seeing this the specimen, again, we can review the terminology. That means the entire specimen is covered by peritoneum, and we can have a sector-shaped mesocolon, which is actually mobilized one. Next is anterior resection. Usually it is done for a lesion at lower sigmoid or rectosigmoid junction. Practically, it's not for upper rectum because we need to have at least 4 to 5 centimeters of rectal margin as well as mesorectal margin, because mesorectal deposits have been demonstrated up to 4 centimeters from the palpable edge of growth. So in an anterior resection, the most important thing for a terminology is our future level of anastomosis is above the peritoneal reflection. See, the distal stump is divided above the peritoneal reflection, and there is no need of mobilization of the anterior peritoneum at the rectovaginal or the rectovesical pouch. So that's the most important thing. So a purely an anterior resection means our level of anastomosis will be into a peritonealized distal stump. So by analyzing the specimen again, the complete specimen is covered by peritoneum. There is no the raw area, the so-called raw area in the mesorectum. Coming to when to call it as a low anterior resection. We know the sigmoid takeoff. We know the peritoneal reflection. Now this is the game between peritoneal reflection and anorectal junction. Peritoneal reflection, anterior peritoneal reflection and anorectal junction. So in a low anterior resection, the anastomosis lies below the peritoneal reflection but above the anorectal junction. So invariably, we need to divide the peritoneum completely in the pelvis, including the anterior peritoneum between the rectovaginal or rectovesical space or the recess. Again, it's going to be somewhat lower, but we will be able to see a mobilized stump, somewhat a mobilized stump in the distal aspect, which is slightly above the level of anorectal junction. So by examining this specimen, again we know that there is the upper 1/3 of rectum is covered anteriorly and on either sides by peritoneum. The middle 1/3 of rectum is covered only anteriorly by the peritoneum. We can see non-peritonealized significant area of mesorectum all around in this specimen. So this is a low anterior resection. When to call it as an ultra low anterior resection? I don't know where this has come, but it carries some meaning. This is usually done for a lesion in the mid rectum. So when to call it as ultra low means the anastomosis lies at the anorectal junction. So once you divide the distal stump using a stapler, it is almost in flush with the level of lever traini muscle. That's a clue. Then we can say potentially this is an ultra low anterior resection. So practically not much mobilized stump in the distal aspect. So again, by seeing this specimen, we know there's a significant length of non-peritonealized rectum and mesorectum in the specimen. Now there are three entities: partial, subtotal, and total intersphincter resection. Usually it's done for a T1 to 3 lesion, preferably T1 to 2. Some cases of T3 lesions after neoadjuvant chemotherapy. And this is just a thickening. This is a normal wall, and this is just a thickening. So when to call it as a partial intersphincter resection, which can be done stapled as well as hand-sewn. So this is an intersphincter dissection between the lever traini muscle and the circular anal fibers of the rectum, and with great difficulty and push, and you can see actually a hollow or recess below the level of the anorectal junction. That means below the level of the pelvic diaphragm or the puborectalis sling. And almost always the donut will show some black anoderm or the hemorrhoidal tissue, or practically it is at the anastomosis at the level of dentate line. When to call it as a subtotal means the final anastomotic line is below the dentate line but above the anal verge. So it's almost practically the same. The only thing is that it's very difficult to do it with staplers. Almost always it involves hand-sewn colo-anal anastomosis, but it is between dentate line and see in this here we can actually see this is a perianal skin. This is a anoderm. There is something here that is at the level of dentate line. Again, from the specimen we know we can actually see the mucosal tube or with the internal anal sphincter. Only the internal anal sphincter is there at the end of the specimen. When to call it as a total intersphincter resection? This is done especially when the lesion shows some carpeting, especially in the submucosal tissue, not exactly through the musculosa, to usually after a neoadjuvant treatment. And here the total intersphincter resection, the initial mobilization, everything is almost the same, but you can see the post-chemo changes there. But we need to have some kind of retractor, and we do the perineal dissection from below. And once the specimen is out, again it's a hand-sewn coloanal anastomosis, and a part of the the anoderm is removed. So finally, the total ISR, the level of anastomosis at the anal verge. Even from the specimen, we should be able to see the skin, practically the anoderm. So preoperative radiology, especially the sagittal section of MRI or contrast CT, intraoperative assessment, and study the specimen as well. So APR doesn't need much definition actually. A large lesion, usually T3, extending into the anal canal, where we cannot actually save the external sphincter. A bit of internal sphincter involvement, again, still we will go for some sphincter saving surgery, but here it is not possible. So there is nothing much in this. Only thing is that, see, after the abdominal component, we do half division of the mesocolon, then division of the sigmoid colon for the permanent end colostomy. And this is a perineal dissection. And we go just outside the external anal sphincter. So that is a routine APR. And we have a smaller wound and we can close it primarily. So that's a difference for the next item. So again, when we see the specimen, everything is intact. There can be some amount of wasting at the anorectal junction. It may not be important for an early lesion, provided our CRM is negative. The last item in the list is extralevator APR. Definitely, this is something like an advanced disease, and definitely this is before the neoadjuvant treatment. The lower rectum extending into the anal canal. This is the anorectal junction. And still after neoadjuvant therapy, the lesion is still infiltrating the external anal sphincter. There is no other option. Also a bit into the levator trani muscle. So varying portions of levator trani will be taken along with. Sometimes it could be even be an excentrations like along with uterus and ovaries. Sometimes a tip of the sacrum. So there are varying types of extra levator APR. And this is a small video for the benefit of youngsters, and courtesy to Dr. Madhumurali and Dr. Ansar, our surgical oncology friends at Trivandrum. And this is the defect here is going to be larger because we need to have a good CRM in this patient. These are all done for M0 lesions. So we need to have a good survival for this patient with least chance of local recurrence. So sometimes part of the tip of the coccyx, a varying amount of sacrum is also removed. So the only thing is that it results in a very large defect. Definitely, it cannot be primarily closed. The defects will be something like this, and the specimen will be something like. Most often, we will have to do some amount of myocutaneous flap or myofacial flaps, or sometimes prosthetic mesh like that. To sum up, there is need for uniformity in staging, treatment, documentation, as well as standardization. The important landmarks being the anal verge, then the dentate line, anorectal junction, then the anterior petrone reflection, sigmoid takeoff. So sagittal MRI or CT is an important thing. And the lower border of the tumor is mainly for treatment planning. And the level of anastomosis will dictate the name of the surgery. Just to summarize, the sigmoidectomy, usually the IMA superior axis is preserved. Anterior resection, the anastomosis is above the petrone reflection. Low anterior resection, somewhere between the petrone reflection as well as the anorectal junction. Ultra low means at the level of the levator trani confluence into the rectum, the anorectal junction. Partial ISR at dentate line. Subtotal ISR between dentate line and anal verge. Total ISR exactly at anal verge. APR will have an end colostomy in the left iliac fossa. Extra levator APR will have some amount of levator trani muscles removed on one side or either side, usually with a flat closure. Thank you so much, sir.
So before Ramesh and Utpal come in, I think students, it's very important, these last two slides which Dr. Arun showed, that you have to understand that anal verge, dentate line, and anorectal junction, which for us is the demarcation between anal canal and rectum as opposed to anatomist. These three landmarks are very important. And whenever you are answering this question, which is frequently asked in the exam, you have to use these keywords and then define the procedure in relation to these three levels. Ramesh, Utpal. Ramesh, you are muted. Pinesh, please make me also co-host.
Can you hear me now?
Yes, now we can hear you.
Yeah. Okay. I just make these comments because I thought at this time to make the comments would be appropriate for this talk. Yeah. And then we'll move on to the next talk, because the first thing is that the sigmoid becomes the rectum opposite the third piece of sacrum. This is the anatomical definition. And that is exactly what you saw. You saw the horizontal takeoff. It was opposite the third piece of sacrum. So there are two ways to know. If you see the third piece of sacrum, below that is rectum, above that is sigmoid. Second, the extra levator APR cannot be done in the lithotomy position. I am sorry, Arun. Sir. What you showed is not correct, because it will require a flap reconstruction, and most common flaps are the gluteus maximus. That is why ELAPR is always done with the patient in the prone position with the legs spread apart, and the plastic surgeon comes and takes the gluteus maximus. You cannot take the gluteus maximus flap in the lithotomy position.
Yes, sir. Yes, sir.
So it should be done in the prone position. So please take this message. So what we have now done is that every APR, we do it in the prone position for the perineum. So that becomes a lesson in when you want to do the ELAPR. It is not something this thing. So every patient, what we do is after we finish, we do the colostomy. We have divided the colon, mobilized it, we turn the patient over and then do the extraction of the specimen from below in the supine. So It's very easy. The most important advantage is that the prostate, which in this position is anterior, and to do the hemostasis at the base of the prostate is difficult. Here it is at the bottom and it's very easy to do. So I would advise that everybody should learn how to do a prone APR. It takes half an hour to change that thing, but I think it's worth the effort to do it. That is all the two comments I wanted to make on this. Everything else is wonderful and you have completely covered it. And though you kept on saying and or CT, I think the imaging for rectal cancer today is MRI.
Sir, absolutely agree, sir. Some patients with borderline affordability, they may come with a CT already done from outside.
I don't bother. I insist on an MRI. I would even ask the MRI person to do it free. I have got good relationships. I'll ask them to do it free because MRI is so accurate for the fascia and to see the involvement. Especially now, I follow the ESMO guidelines. And so if it is an M1 that is less than 1 to 2 millimeters, I won't give neoadjuvant on a mesorectal fascia. So I believe that MRI is very important. And no matter what, I will do an MRI. I think we sometimes carry this question of affordability a bit too much, but I don't, I even ask them to do it free of cost if possible for some of my poor patients. So these are three small points. We will move on to the next, which is a very interesting talk because I did speak in a debate on it in Coimbatore, and I want Deep Goel, who is chief of surgery at BL Max Hospital in Delhi. He's an old friend of mine. He's always been interested in colorectal surgery, and he is a wonderfully gifted surgeon, and he is going to speak on APR versus intersphincteric resection. Deep, you're on.
Thank you very much, sir. Let me just share my presentation. Is it visible, sir?
Yes, absolutely.
Yes.
It's full screen also.
Perfect. Thank you, sir. So first comment, I would agree with Dr. Ramesh Ardhanari completely that we should not fall into the trap that most of our patients working in a, super specialty hospitals are basically coming from outside, and whether we like it or we don't like it, they are carrying a PET scan as a first investigation after colonoscopy and biopsy being done. But as Dr. Ramesh said, do not be, fall in the trap, do an MRI. Believe me, most of the times you will change your strategy. So with that, I will, okay. So rectal cancer treatment has changed to multidisciplinary approach in last 2 or 3 decades. And we are actually not far. In fact, we are there when AI and the genomic prints will empower us to offer precision treatment and dictate the treatment protocols. Well, it's a $1 million question. How do we choose? Because it's a question of oncological outcomes. It's a question of quality of life. We have to also take into account surgeon's experience and his skills, and do not undermine the patient's preference after counseling the patient and taking an informed consent. Coming to the first thing first, we have to concentrate on accurate staging. And for that, there are so many investigations, but surgeon's finger, I would still feel, is a very, very important tool to assess so many things about the tumor. CT scan to know if there's a disease in the upper abdomen and the chest. High resolution MRI at rectal protocol is the key for the local staging, and that is the one which will guide us. PET CT scan indications are very, very minimal. If you are taking the patient for neoadjuvant treatment, some of the oncologists will insist to have a PET CT, and obviously reassessing the disease after doing neoadjuvant treatment for systemic failure or systemic progression.
And the commission also plays a big role in the PET CT.
Sorry, sir?
The commission that they get also plays a big role in the PET CT.
So the importance of MRI was very, very clearly demonstrated by Mercury trial conducted by Zena Brown in England. And it very clearly shows that circumferential resection margin involvement is significantly associated with not only local failure, but metastatic disease. Also, Mercury 2 trial said that, by accurately staging the disease, you will avoid the overtreatment, and also restaging post-treatment is very, very important, and MRI is the investigation of choice. So the next important question is, what are we looking in MRI? Well, I would suggest that all of us should learn how to read an MRI, but if we can't do that, at least we must know what questions to ask our radiologist. So obviously MRI will tell us about the width of the tumor, that is T1, T2, T3, length, distance from the anal verge, CRM, number of lymph nodes, involvement, EMVI, mucinous content, tumor deposits out of the CRM, and anterior peritoneal reflection involvement. These are all important points which will guide our further treatment. What are the implications of accurate staging? Because there are various treatment options. How do you sequence them? Do you do a neoadjuvant treatment, or you take the patient for upfront surgery? So what we need to do, we need to identify out of our patients who are good patients, who are bad, and who are ugly, because not only they will help us in guiding our treatment, but also they will give us an insight into how these patients are going to behave.
You have changed the ugly and the bad. Sergio Leone was actually the ugly, and Lee Van Cleef was actually the bad.
Ramesh, that's the problem of having you as a moderator. You have such a keen eye. I'm sorry about that. Okay.
It was just a joke.
I know. So this was published an editorial in Acta Oncologia, where they very clearly said that good tumor in the upper rectum, mid rectum, lower rectum, their definition may change 3A, 3B according to the site and lymph node involvement, if not there, and CRM negative, can be taken up for upfront surgery. There can be some difference between the philosophy between Americans and Europeans, but we have to see what is good for us. And when we talk about bad tumors, that is the later part of the T3, C, D, and if there are positive nodes or involvement of adjacent structures like vagina, then we give neoadjuvant tumor. They are classified as bad. And ugly tumor are mostly T4 plus tumors. Their chances of local recurrence are up to around 50 to 100%. You obviously give neoadjuvant treatment. Now the question is, how does NAT help in rectal cancer management? So it downstages the tumor. It can downsize the tumor. Sometimes in a narrow pelvis, tumor is very bulky. It may not be T3, C or D tumor, but you still want to downsize the tumor to decrease the local chances, recurrence of local recurrence, and to decrease the deposit of the tumor in the surrounding area, decreasing the chance of micromets, especially if patient has EMVI positive, and you need to maintain negative CRM margins of at least 1 millimeter. When do we reassess the response of neoadjuvant treatment? So if you look at these pictures, left side picture, there is a compromise of the intersphincteric plane, as the yellow arrow is showing on the left side. And after neoadjuvant treatment, that has been cleared. I'm not going, because of the paucity of time, into the detail of tumor regression grades. So another picture showing that free on the left side and compromise on the right side. So again, when I was coming to importance of MRI in CRM, you can see if it is positive CRM, chances of local recurrence are almost up to 50%. Again, depending upon what is the margin of CRM, we definitely require more than 1. If it is more than 2 or more than 5, it does not decrease the chances of local recurrence. Again, you see in this picture that CRM on the left side is less than 1. So obviously this patient went for neoadjuvant treatment, and at the reassess MRI or restaging MRI, it is more than 1 millimeter, showing that neoadjuvant treatment has actually done a good job, and this patient can be taken up for surgery. Another important point of debate, distal margin, how much is enough? We remember from our medical school days that classically in low rectum, we used to say that we need 2 centimeter margin, but things have changed in the era of neoadjuvant treatment. Today we are talking about, we talked about from 2 centimeter to less than 1 centimeter. If you look at these data, it very clearly shows that there's not much difference between more than 1 centimeter and more than 2 centimeter. But yes, we do not want less than 1 centimeter as per this report. But now, as in patients where more and more favorable biology, patients who have undergone neoadjuvant treatment. Today, we are talking about even a margin of close to 1 millimeter. So in fact, if patient insists that he wants to save the sphincter, you have a patient who has undergone post-neoadjuvant treatment, you have a patient who has a favorable tumor biology, we can do any margin which is microscopically negative. Coming to the concept of total neoadjuvant therapy, which is in last couple of years is catching up. What does it mean? It means total chemotherapy and or radiation protocols are given before surgery or sandwich in between the whole treatment. It increases the complete pathological response. Some of the papers, repeated trial is showing that up to 38% complete response being seen with total neoadjuvant treatment. So what are the indications? If you have a large, bulky, ugly T4 tumors, if the number of lymph nodes are larger number, MRF is positive, EMVI is positive, you will consider these patients for TNT. Not all rectal cancer will need TNT to be on record. Patients who have an intermediate grade, now there is enough evidence that even just giving chemotherapy may give you the same results, or just doing only radiotherapy will give you the same results. So what are the advantages of TNT? You can give full dose of chemotherapy early in the course of the disease, which may address the micrometastasis and better tolerated by the patient. And stoma requirement for a shorter time, because once you have finished all the chemotherapy, you do the surgery, you put the stoma, and you can reverse the stoma within a month. And some papers and some centers practice after even 2 weeks, they reverse the stoma. If you're not completing your treatment and if you're doing the surgery in between, then you will have to wait till you finish all your adjuvant treatment then. And if you have chosen to do TNT and a patient has a complete response, then you can maybe selected patients after discussing with patient can be kept for watch and wait approach. Another important question is, when should we assess tumor response? If we are following a classical protocol where we give a long course radiation and then we are waiting for the response, today we say that, wait for around 8 to 12 weeks. And in our center, we normally wait for 10 weeks and then reassess. But there's a lot of literature available which says that the longer you wait, the PCR rates are higher. Like in this particular paper, it is ranging from 6 weeks to 19 weeks, and you can see the response from 18% to 38% respectively. Whether it is because of the consolidation chemotherapy or it is because of the prolonged period we have waited, it is difficult to actually ascertain. What is also important when you're taking these patients for neoadjuvant treatment, to know whether these patients are actually responding or not. Because if you keep on giving TNT and there is obviously 40% people who are not responding as per expectation, then probably you are losing out on the time for surgery. And it is also shown that people who wait for longer period in patients who are not responding as expected, their overall survival and disease-free survival is significantly worse. So that brings us to the question that when should we reassess in these patients? Sorry for this confusion, 1 second, yeah. Or can we predict a set of patients whom we think are going to be poor responders, and we need to formulate a strategy where we can reassess them earlier than later? So people who are having poorly differentiated adenocarcinoma, multiple nodes, EMVI positive, large mucinous content, CRM positive or ISR positive before starting neoadjuvant treatment, these are the patients for whom we have to keep an eye and obviously assess them early in the part of the treatment and then formulate our strategy. Local excision again is becoming popular. There are certain criteria. If tumor is less than 3 centimeters, involving less than 30% of the bowel circumference, and you have done an endorectal ultrasound or MRI or both, sometimes it is required, and tumor is limited to submucosa, no lymph node involvements, well to moderate differentiated, absence of lymphovascular perineural invasion, and no mucinous or signet cell component. These are the patients who can be considered for local excision. There are various techniques available, but as far as low rectal is concerned, it is only transanal strategy. There is some literature which is available which says that local recurrence rates after local excision in low rectal cancer are higher as compared to TME. But when you apply neoadjuvant treatment in these patients and then do local excision, then the recurrence rate and overall rates, oncological rates, are similar to TME without any disadvantage of TME in form of losing the organ or in form of anterior resection syndrome. Artificial intelligence is coming in a big way, and this is a very interesting article which I could lay my hands on, where they are applying algorithm on MRI pictures in various pre-designated factors, and then they are predicting that probably this particular patient is not going to respond as expectedly by neoadjuvant treatment. Intersphincter resection, Dr. Arun has already told us in great detail. A few slides, I would say that one has to be careful about functional results and oncological results, because the more and more aggressive you are with ISR, you really need to choose your patients very, very carefully. But if you look at the data, data says that there is no oncological disadvantage. And in most set of the patient, even the functional results are as expected. And this article says that around 81.6% of the patients were satisfied with the functional results of the surgery. But the downside is that they have not taken into account different forms of ISR, subtotal or total. What I would say that you have to be very careful as a surgeon, that you inspect the functionality, the sphincter function of that patient. You have to see comorbidities, you have to see age, you have to see gender, because in women, most of the times the sphincter function may not be as good as in men. So you need to do a proper digital rectal examination. You have to have the knowledge of anatomy. You need to transport your images, especially the MR images, to your operation room and visualize what operation are you doing, what are the organs involved, where is the sphincter and how are you going to cut, where is the anastomosis, how is the CRM, everything together. You need to apply your mind to that particular patient. You need to, obviously, as I said, look at the health of the patient, sphincter function, and at the end, obviously, you need to have a very open discussion with the patient that what kind of functionality is the patient expecting and what does patient want. Obviously, no patient would like to have a stoma, but once you tell them and guide them properly, you'll be surprised that some of the patients will choose to have a permanent stoma rather than having an inadequate function. Watch and wait, we have already said this was popularized by Angelita Hybergama from Brazil, and it is now becoming more and popular in selected patients. Same thing. So look at this picture. On the left side, we have a patient before neoadjuvant treatment, which is involving the internal sphincter and a part of the external sphincter. But after neoadjuvant treatment, you see how the disease has restricted and it has responded very well, and this has been converted to an ELAPR. If you cannot save the sphincter, I would say today treatment of choice, a surgery choice is extralevator abdominoperineal excision. And this is the specimen which you will see on the left side where you see the wasting, and on the right side is the extralevator, which is leads specimen. Now look at this picture. How do we choose? So ultra low cancer, a cancer which is abutting top of the internal sphincter, distal margin can be achieved, highly motivated patient, good sphincter function, preferably male. You can get away by doing intersphincteric resection and avoiding a permanent stoma. On the other hand, if you have a patient where a sphincter is involving the levator muscle or the external sphincter major part, there's a poor sphincter function, the technically challenging procedure in terms of patient morbidly obese, narrow pelvis, or any other problem, patient after being counseled wants to undergo, after understanding the implication, and probably a female patient, multiparous patient, I would probably do an APR. So that's my presentation. Thank you.
Thank you, Deep, for a wonderful presentation. I have a couple of points before we move on to the next speaker,
Sir.
because these have to be brought in now so that people can debate it when they come to a thing. First of all, I do not believe in Shailesh Kundapegar's paper. It goes against every other paper in literature. I spoke on intersphincteric resection versus APR. I spoke on the side of APR at the Coimbatore colorectal surgeons meeting. And I reviewed the literature. From Korea, Japan, China, everywhere, the rates of complete incontinence vary between 50 to 75%, and rates of partial incompetence and incompetence at night with soiling of clothes varies from 75 to 90%. So it is not a good operation, intersphincteric resection. It's a poor operation. To say that highly motivated patients, I have gone also on to the blogs of patients who underwent intersphincteric resection, and they've invariably cursed their surgeons for not warning them what they were expected. And many of them in the USA have changed it back to an APR because they said, I like to ski, I like to swim. With an ISR, I need to be near a toilet within 20 minutes because I cannot hold my motion more than that. But with an APR, I can be free of all this. So there are a lot of disadvantages of ISR which are not mentioned by the surgeons to the patient. And they force them, and then the patients are miserable. So I did do an analysis, and I came to the conclusion that if I had to have a operation, I would never have an ISR. We voted the audience before the surgery. There was about 20% who said ISR and 80% who said APR for a particular case which is in the lower rectum. After the surgery, the only two people who voted for ISR were Senthilnathan and Rajapandian, because Rajapandian spoke and they are both from Gemma Hospital. Every other person lifted his hand in favor of APR. So I was able to convince my audience. So there is a lot of things which are not said in literature. That is one point. Second point is there was one slide where you actually showed that there was good response and so you could convert it. But actually, if you looked at the slide, the CRM before surgery was less than 1 millimeter, and after surgery was great. After radiation and chemo was greater than 1 millimeter. Actually, that had progressed. So that is not a good sign. Anything that progresses is not a good sign. So that
it was before. Sorry, if I may make a comment on the first point which you have raised. I personally completely agree with you, sir, that ISR may not be a good choice of the procedure. But again, since we believe in literature, that today literature says, and there's a very large paper which has just come out from Tata Memorial Hospital by Saklani Group, which very clearly mentions that their functional results are very, very good.
I am sorry. I do not believe Indian functional results. I am sorry. The entire results, I am unable to believe. The rest of the world says 80% incontinence, and these people say that we have 80% continence. How can I believe that? Everybody else in the world has bad results.
Any paper coming out from Tata Memorial Hospital have to be given.
No, I don't believe. I don't believe that. I don't.
But as you rightly said, as a student of science,
Ramesh,
it is a job.
Ramesh, sorry to interrupt, but let us keep the kind of the whatever is
scientific.
We have to
I am
accept.
saying that everybody in the world has one result and we have another result, which is very surprising, which I don't believe. I have received patients who operated for ISR.
You should generate a scientific debate. You should do a good review of the published
literature. I did do it. That's what I'm saying. I did do the debate.
Let us do the discussion for students. Let us do the discussion.
Yeah, we will do the discussion for students. But I did do a very scientific research, and I have got the figures to prove it also in my somewhere in my slides.
So, sir, I would like to rephrase and say that what you are saying is not wrong, but as a student of science, we have to give importance to literature. But at the same time, we should be mature enough to interpret the literature and apply it to our patient as we think is right for the patient after a frank discussion. That's what I was trying to tell you.
So with this frank discussion, does it take? We'll go.
Let me. What I would say that there are so many publications. Only one publication talks of 80% good results, whereas rest talk of 80% poor results. That's what you said. So it is up to me whether I want to accept that article or the rest of the literature when I am counseling my patients. That is what.
I look at the literature. Sorry, I
Yes,
looked at a
indeed.
lot of literature, and I was looking for what Dr. Ramesh is saying, but unfortunately or fortunately, there's a huge amount of literature available which now says that functional results are comparable, which is very difficult to digest. I would agree with Dr. Ramesh, but
No, but is it from foreign
it is from
Korea? Is
foreign.
it from
Absolutely.
Japan? Is
Most
it
of the
from
literature is
USA?
foreign. Absolutely.
So I have
And
not found those literature. Let us see.
keep the discussion restricted to what is going to help the students in the
Yeah.
exam. So this is a teaching session.
And
So
coming to the second point,
I would say to the examinees that junior surgeons should, as far as possible, avoid intersphincteric resections. The results in the hands of inexperienced surgeons are going to be much worse than that of experienced surgeons. So I would say that they should talk to them about the advantages of APR, and APR is not a bad act. There are many papers which show that APR is not a bad operation. And so they should stick to that. And I think once they become experienced, then they can start doing ISRs. They have learned it, then they can choose the right patient and do it. That will
Utpal,
be
any
my
comments
advice.
on the two
Yes.
presentations?
Yes, sir. I want to ask one question, Dr. D. Very nice presentation. I almost covered every aspect of LAR and AR. But one question from resident point of view. This most common thing that these two operations are done mainly for tumors less than 5 centimeter. And my question is, if there is bulky tumor and you have undergone neoadjuvant chemotherapy, and there is a almost complete response, then how will you decide to go for LAR or APR? And intersphincteric dissection is not very much popular in India, and the functional result is not good. And from resident point of view, it's not at this point of time to know much about intersphincteric dissection. Most important thing is to decide in bulky tumor if it has got good response after neoadjuvant chemotherapy. What should be the strategy? Whether should go for APR or LAR?
so
Sir,
again, Dr. Utpal, you have to go back and we have to see whether I can achieve CRM, whether I can give you a good distal margin and without causing any compromise. And if I still have a good length distally where I can have a good functioning anal canal, obviously I will go for a low anterior section. But again, as Dr. Ramesh was saying, if you are a new surgeon, you do not want to do ISR, you can't give, without doing an ISR, you can't give a CRM, then probably you have to discuss with your patient. And I would, go to an extent saying that it is not necessary that you have to do an operation, though that is a practical point. But if you think somebody else can save the sphincter and give a good function, and you are not the right surgeon, maybe refer that patient to that center.
Yeah,
No,
maybe.
my question is, how will you re-stage the tumor? Because the tumor was bulky at the first. After
Oh, you
giving
mean-
neoadjuvant chemotherapy,
So you need
it has
to-
shrink.
If you have denied,
Now you have to decide between the LAR and APR. In the tumor, say it is
Yeah,
around
you
4
have,
centimeters
these are
from
the
the anal.
following, these are the following investigations you have to do. You have to do a diffusion weighted MR, because that is the
Diffusion weighted
best.
MR is not very popular in India, sir, because most of
But-
the center, almost 90%
Yeah,
of the
but-
center, no one is doing diffusion. Even
We are doing in our place.
in
And that
very,
is
very
very good
selected
to
center.
tell you. That is very good to do because it tells you whether tumor is there or not. So
Still,
if
there
you
are
have
many
tu-
papers that contradicts many results of diffusion weighted MRI.
But we are
So there
still
are-
doing that along with a good rectal examination, multiple blind biopsies, and we do a PET scan. Now, the PET scan still highlights the lower rectum. I would do an APR. If the PET scan doesn't highlight at the lower rectum, and I can get a centimeter of rectum above the elevator, and I will do a ultra low anterior resection. But I do not believe in this intersphincteric resection, and I do not advocate it to my patients.
can I make a comment, Dr. Utpal?
Yes,
see,
sir.
if you do not have a diffusion weighted MRI, do a routine high resolution MRI. So there are 3 categories, so patient has a good response, patient has a near total response or a poor response. So the problem happens in a near total response. Poor response, it's an outlier. You have to do APR. Good response, you can get away with anterior section. Problem happens with a near total response and the interpretation of a near total response, because sometimes what is seen as a disease is just a fibrosis or a acellular mucin. So that is where the problem lies, and you definitely require a very good radiologist to guide you there, and a digital rectal examination to see what kind of response you have, what is the mobility, what is the distal margin available. So all this will definitely guide you, and obviously a lot of maturity and experience is required to make a decision in these kind of patients.
And if you find that there is complete response, there is no tumor on biopsy, there is no tumor on visualization with a colonoscope, your PET scan is negative. These are patients who I would think are complete responders, and these patients I would put on wait and watch policy. So anybody who has to lose his sphincter, I'm aggressive about wait and watch policy if they've had a complete response. We now have 13 patients who have been on wait and watch policy. Only one has gone on to APR. The longest follow-up is 4 years at the moment. And he has not, and he comes for regular follow-up, and we do this proper examination. And wait and watch is also a very good policy. I think we are going to see more and more of it because radiation and chemotherapy are improving so much that we are going to see more and more of it.
Couple of points, couple of caution about what Dr. Ramesh is saying. It is at the moment not standard of care. You have to really discuss with the patient. The patient should be absolutely willing for a very, very strict follow-up.
Yes.
And repeated costly investigations.
Yes.
Yeah, but many patients are willing to pay for that if their sphincter
absolutely
can be saved.
What I'm saying is they should be offered to the patient, but you as a surgeon also have to look at whether this patient is likely to have a follow-up with you or not. And
most of them,
especially
a lot of them are coming.
Especially younger patients. Now there is a literature available that if they fail, the rate of metastasis is higher in these patients, not only local recurrence.
Sir, anything to do with
there are 2 or 3 questions on the chat from students. Khalid Durrani wants to know what should be the neoadjuvant protocol for tumors of the upper 1/3 of the rectum. I would add to that do you treat them as CA rectum or do you treat them as CA colon?
Please go ahead, sir.
I treat them as CA colon. So upper rectum, unless it's very bulky and has multiple lymph nodes or it is infiltrating the anterior abdominal wall, I don't give neoadjuvant treatment. I will go upfront surgery and then give adjuvant treatment.
Deep, your take on this?
Absolutely, sir. Upper rectal cancers are treated as a colonic cancer. Unless they're very, very bulky, as Dr. Ramesh said, then maybe there you will give neoadjuvant chemo rather than radio.
Yeah, chemo.
Dr. Khalid Durrani also has made 2 comments. I will read them out. He says that it's important to highlight that procedures such as intersphincteric resection, transanal TME, they are successful in specialized high volume centers. For an average GI surgeon, probably he has put a question mark, but I think we have already covered that.
I just want to tell him that the transanal TME is banned at the moment in Sweden and Norway. After their analysis of interim results, they found such high local recurrence that they have banned it at the moment till people can get trained and do better surgery.
The other comment he has made that the oncological results should take priority over functional outcome. That of course is general. There's a question from Dr. Sundar Shresth. He asks what would be the surgical plan for a tumor which had involved the sphincter and now has got neoadjuvant treatment, and post neoadjuvant sphincter, the sphincter is free. Now this is a very frequent question which is always asked for all cancers following neoadjuvant treatment, that what decides the extent of resection? Is it the pre-neoadjuvant extent of the disease or is it the post-neoadjuvant extent of the disease?
Can I just first butt in with my opinion? We were taught based on head and neck cancers, which were squamous cell carcinomas, that the margin of resection should remain as the original margin of the tumor. But I think when we're dealing with adenocarcinomas, that concept has now changed. Adenocarcinomas seem not to come back in the areas from which it has vanished. So if you are confident it has vanished, you can now use the new edge of the tumor to decide your line of resection. This is my opinion.
I think I would completely agree with Dr. Ramesh. I will add that you also have to take into account the tumor biology. If this is a poorly differentiated adenocarcinoma, signet ring carcinoma, a lot of mucinous content, I would be probably, maybe err towards the abdominal perineal section rather than doing an ISR in these patients.
No, but more important is the circumferential spread. See, for example, suppose bladder was involved to begin with, or you thought that it is involved, or vagina was involved, and now post neoadjuvant on imaging, it appears as if there is a plane. So do you go into that plane or do you?
No, vagina is sacrificable. Bladder wall is sacrificable. Whatever is sacrificable can be sacrificed.
Should be sacrificed.
Should be sacrificed.
Then you are going by convenience rather than by any
Yes.
principle. That
Yeah,
what is
this is-
convenient, you resect, what is not,
Yes.
you.
That is
Yes.
that you
That
have
is-
to take into account
that is-
tumor biology and have a very, very frank, informed discussion with your patient.
And another thing, Dave,
Sir.
poorly differentiated carcinomas and mucin secreting carcinomas, they don't cause problems with their local recurrence. They cause distant metastasis and kill the patient. So even if you sacrifice, you go a centimeter, you will give him a continent thing, but he will die in 2 years of liver mets. So
Their response to neoadjuvant treatment is not complete most of the time.
is not good. But they will go for distant mets and die.
Yes.
They don't die of local recurrence.
Right, sir.
No, so what is the specific answer to the question that pre-neoadjuvant sphincter was involved? Post-neoadjuvant sphincter is free. Would you preserve the sphincter? Would you
Yes,
sacrifice?
I would preserve the sphincter.
Discuss with the patient, sir. Give him
I would
the
preserve.
true
My-
picture and take his
So
opinion.
what would you tell the patient? What exactly would you tell the patient?
I will again come to the same thing, sir. If his pre-neoadjuvant biopsy is well differentiated adenocarcinoma, no other high-risk features, I will probably err on the side of doing an ISR. But if patient also wants that, I do not want more chances of recurrence and tumor biology is not favorable, I will do an APR.
Elderly
Well,
patients, women should have APR because they can't control their ISR very well. So they should preferably have APR. Elderly patients also. You can add to your.
Utpal, what would you do in a case like this?
Sir, I will prefer APRs because
Yeah, so there are two schools of thought, but there seems to be a school of thought because we have now said that neoadjuvant treatment downstages the tumor. We have now got this evidence. So if it downstages, then we have to manage with the new stage. That is my argument.
Okay, I think we can go on with the next. Ramesh,
And the next speaker is a very distinguished gentleman. He is from Christian Medical College in Vellore, which is my alma mater also. And he is a very good colorectal surgeon, has got vast experience in colorectal surgery, works and heads the Department of Colorectal Surgery at CMC. Do you have an MCH course in colorectal at the moment? I am not sure. I think they are applying for it and they should soon have it. And Rohin Mittal is going to talk about how to do low anterior resection. Rohin.
Before Rohin
thank you.
starts, a special thanks to Rohin for chipping in at my request at the last minute. Dr. Deepak Goel was supposed to do this, but he had to rush to US for some family issues, and then he requested Rohin. So thank you, Rohin, very much for joining.
Thank you. Thank you, sir. Thank you for inviting me.
Your sound is not clear, Rohin.
To be
Rohin,
here.
your sound
Thank you,
is not
Dr.
clear.
Ramesh,
Yeah.
for that introduction. Is it better now, sir?
Yeah, it's much better.
Is it better?
Yes.
Oh,
Yes.
Okay, sure. I've just amped up the volume. Again, thank you to Dr. Kapoor for inviting me, and thank you, Dr. Ramesh, for the introduction. We've looked so far at terminology, and then we've looked at a little bit about decision making, which can be quite difficult at times, as we've seen. The next bit of it, I think we're going to look at the technical aspects of how to do a low anterior resection. We should all understand that a low anterior resection is a complex operation. It is not something you will do as your first operation. It has a lot of steps and a lot can go wrong. And as we have discussed, quality of surgery is key to good outcome in low anterior resection. A badly done anterior resection can be worse than a well done APR. And what is a good outcome in a low anterior resection? It's an operation with minimal complications or no complications. We have minimal or low recurrence rates as much as possible, and the patient should have a reasonably good quality of life. And we've got to achieve all three if we say that our low anterior resection is actually successful. Now, we can do it open, we can do it laparoscopic, we can do it robotic. The one you should choose is the one you are most comfortable with, where you can perform it in high quality and with the equipment that you have. Now, what are the key steps to a successful low anterior resection? The most important bit is the preoperative preparation. If you don't prepare for the operation, your operation is likely to fail. what about the intraoperative steps? Again, it is a complex operation, but we can break it down to multiple small steps. We learn these steps and we do them well, and the complex operation becomes simple. And then, of course, you've got to have good post-operative care. So I'm going to dwell a bit on each of them, and then we will discuss the technique as well. So now, preoperative preparation is absolutely important in doing a low anterior dissection. First and foremost, like our previous speakers have said, we have to review the MRI scan. We've got to look at the location of the tumor. We've got to look at the circumferential margin. We've got to look at the distal margin and see where our transaction point is likely to be. And then a very important point is to look at the size of the pelvis. A narrow pelvis is going to predict a difficult operation. A wide pelvis, the operation is likely to be slightly easy. Additional things to look at is, if you can, is to look at the IMA and its branching pattern, and also to look at splenic flexure anatomy to see whether it's a deep splenic flexure or it is something simple, because sometimes in a low anterior section, you will mobilize the splenic flexure. Now, these are some pictures of the MRI. We've already looked at some here. You can see that the tumor here is quite low, and you might have to almost do an intersphincteric resection or an ultra low anterior section in them. Here you can see the tumor is here, and anteriorly the margin is close, and you've got to be careful at that point of time. Again, other factors to consider before you embark on an LAR is to assess the other patient factors. Older patients, patients with pre-existing sphincter dysfunction, patients who've been radiated might not be ideal candidates for low anterior section. A very important thing is to plan the operation and to do the operation in your head before you actually do it on the patient. You should go through the steps, plan every step, and then only go and embark on this operation. Look at what instruments you will need. If you're going to do an open anterior section, you might need a St. Mark's retractor, you might need a headlight. If you're planning to do it laparoscopically, plan your staplers and make sure that they're available. Think about whether you're going to do a stoma, and if a stoma is planned, mark it preoperatively. It's always better to have a stoma marking preoperatively than to choose a spot on the during the operation. And then think about bowel preparation. We routinely bowel prep all our patients, but some people don't. But you should know what you're doing and do accordingly. Once a good preoperative preparation is done, we come to the technique, which is
your voice is breaking up.
Steps. Now again, like I said,
no, your voice is breaking up. Your image is frozen. I think there's an internet problem.
Hold on, I'll take off my headphones. Is it okay now, sir?
Yes,
Better?
yes. Yeah, yeah. The voice is fine, but the video is not moving. Your video.
Can you hear me, sir?
I can hear you clearly now.
Okay. Okay. What I will do is I'll switch my video off. That might become better.
Yeah, okay.
So very important is patient positioning. Patients are positioned on a modified lithotomy position. We need patients to be steep Trendelenburg and left side up. This is because the small bowel needs to go up into the right upper abdomen so that we get a clear view of these Allen stirrups. If you don't have Allen stirrups, we can use normal stirrups as well. We have to have some kind of an anti-slip mechanism on the table, because when we give steep Trendelenburg, the patient slips down. A bean bag or an anti-slip mattress is ideal. The hip really should be at the edge of the table. If the patient slips and the hip is not at the edge of the table, we'll find it difficult to staple. And both hands should ideally be tucked in so that we have enough space for us to operate. Now, I'm going to talk mostly about, so this is the position that we usually do. This is one of our patients. We've got the Allen stirrups here. The patient's at the edge of the table. Both hands have been tucked in, and we've got this anti-slip mattress so that the patient does not slip down. Now, actual operations, like I said, we can break it down into multiple steps. The first step is port placement and exposure. Then the next step is mobilization of the sigmoid in the left colon with IMA ligation. Then the next step is pelvic dissection. Then we do the mesorectal and rectal transaction. Then the specimen is extracted. And then finally, the anastomosis and stoma is done. And we're going to go through each of these steps in a few minutes. So this is the port placement that we use. Now, this varies across hospitals. I know there are people who use the camera port at the umbilicus, but this is what works with us. Whatever you have learned and is comfortable for you, you can use. This is one of the configurations. We have a 12 right post
Your voice is breaking up again.
for this.
No, voice is breaking up. No, the voice is not clear. No, voice is not clear. Rohin, have we lost contact with you? I think we have lost connection with him. We'll wait till he comes back.
Am I audible, sir?
Yeah, now you're audible. Yes.
Okay, sure. Sorry about that. So I'll go back to full screen again. Yeah, so we've got a 12 right iliac fossa port, a 10 right lumbar port for the camera, and then a right upper quadrant port for the left hand, and an assistant port on the opposite side. First step is exposure. Again, like I said, Streep Trendelenburg, left side up. And the first step is to reduce the momentum into the upper abdomen and flip the small bowel mesentery cephalad. And in females, we can suspend the uterus. In males, we can even take a stitch through the bladder to suspend the bladder. So now this is how it looks. So you can see the momentum that is there. The first step is to take the momentum and physically place it in the upper abdomen. And you can see what we are doing. We are flipping the bowel. I'm not holding any bowel, but the bowel is being flipped over. So that it goes and the weight of the mesentery.
Do you have a bag or something under the pelvis?
No, sir. Usually, we used to put a sort of bag under the pelvis. Now, just with Sleep Trendelenburg, it usually
You are
comes
managing.
to
Okay.
a good 30-45 degrees. So you can see here that, we have mobilized right up to the duodenum here. You can see the D3. You can see the aorta. You can see the aortic bifurcation. The whole left colon is visible, and the pelvis will also be visible. So this exposure is very important to be able to do a good low anterior section. If the small bowel keeps falling down, we won't be able to do a good operation.
You said you do bowel preparation. For the benefit of the PGs, what bowel preparation do you use?
So we use mechanical bowel prep. About 36 hours before the operation, patient gets liquid diet only. One day before the operation, at morning 8 o'clock and evening 4 o'clock, we give Exelite, which is sodium picosulfate, 2 doses. And that's our protocol for bowel prep. We do not give antibiotic bowel prep.
You don't give oral antibiotics. Okay.
Don't give oral antibiotics. There is some evidence that oral antibiotics may help, but we currently are not practicing.
Okay, agreed.
Yeah. So this is again a small video to show suspending the uterus in females, which again helps in retraction and makes the operation easier. So we just take an awl. You can use a straight needle if you have a straight needle, and just suspend the uterus on both sides. In males, if the bladder is falling, we can take a straight needle and suspend the bladder as well. And it just gives a better view of the pelvis. Now, the next step, once we've done this and we've got access and the whole operating field is clear, is that we mobilize the sigmoid and the descending colon. The sigmoid is retracted cephalad, the peritoneum is incised, and a retromesenteric plane is made, hugging the IMA and the mesocolon and safeguarding the ureter and the gonadal vessels. The tip here is to stay close to the IMA to preserve the nerves and not go away from the IMA. And then we do this dissection laterally till the lateral abdominal wall, till the whole left colon and sigmoid is free. So now, then the IMA is ligated at its origin. And the IMV has got to be ligated at the inferior border of the pancreas, because that's how we get enough length for the colon to come down for the anastomosis. And the retromesenteric plane is developed till the lower border of the pancreas, the splenic flexion and the lateral abdominal wall. So we will see this in a video now. So this is where you make your initial peritoneal cut. The sigmoid colon has been retracted up. And once you make the cut, the air goes in, and then you can see the plane. You can see all this sort of air going inside. The key is to stay closer to the colon and not go towards the promontory, because that's where the nerves will be. A very important thing is to see how the left hand works. So you got to A-frame your instrument here, as we see, and then move it away and out so that you get good visualization. And then you just take all the tissues down. You can see that the ureter is here. That's the gonadal vessels there. and all of them come down. It's a very bloodless plane.
So that is the left ureter.
Yes, sir. Left ureter. That's the left ureter, and then the left gonadal vessels. And then you again, as you can see here, I'm hugging the IMA and cutting this. There's a triangle which forms. You go to the apex of the triangle and cut the tissues and sweep everything down, staying very close to the mesocolon so that you don't damage any of the nerves. So I've slowed this video down just to demonstrate what plane we are supposed to stay in. And then you can see that the IMA is in this. This whole dissection needs to be done right till the lateral abdominal wall so that the whole colon is actually free. So you can see that the gerotas is coming up here, and now we are taking the whole thing down up to the gerota. So the difference in fat between the mesocolon and the gerotas can be seen. And once we've done that, we can go right up to the origin of the IMA. You hook the IMA, and then you can clip it and divide the IMA there. So that's the height, classical height eye, where it's almost at its origin. So we usually put 3 clips, 2 proximal and 1 distal, and then cut the IMA there. Further, the IMV is mobilized. Now here I'm taking it slightly low, but you can follow the IMV up and take it right at the base of the pancreas if you want more length. And then once again, little bit more mobilization laterally. Here you can see that the gerotas and the perinephric fat is being taken down so that the whole left colon is then free for us to sort of mobilize and bring down into the pelvis as required. Once this bit of the dissection is done, then we go laterally, and all we need to do is just cut the peritoneum and the whole. So here you can see we're going right up to the base of the pancreas. So you keep doing this, and then the lateral dissection becomes fairly easy because we've done most of the dissection from medial to lateral. You can see this sort of purplish discoloration, which tells us that we've dissected that from below. And as you cut the peritoneum, you enter your previous dissection field, and you can cut this peritoneum right up to the splenic flexure, and the whole colon distal to the splenic flexure is then free for us to use for bringing down to the pelvis. So once we've done that, then we concentrate on the pelvis. The pelvic dissection, the order of dissection is posterior first, lateral next, and anterior last. Anterior is the most tricky. Posterior tends to be easier. And if we go in this particular fashion, the TME becomes slightly easier. It's circumferential dissection in the TME plane. You can go right up to the pelvic floor and into the intersphincteric groove if required, preserving the hypogastric nerves. The anterior plane is the most challenging because in women, there's a risk of entering into the vagina or damaging the seminical vesicles and prostate in the males. So now this is again same patient. Now the rectum and the sigmoid is being pulled up, and we are going down into the pelvis. Again, you can see that I'm actually hugging the mesorectum rather than going down here where there's also a plane, but that plane will be below the nerves. So we stay close to the mesorectum, but keep the mesorectal fascia intact. We've got to be careful here because the ureter and the nerves will come there. As you can see, very shortly, you'll be able to see the ureter peristalsis over there. So that's the ureter peristalsis. And you can see how close it is. And you've got to be very careful of that. Once you go into the pelvis, dissection becomes slightly easier because there's a lot of areolar tissue over here. You can see this structure here. That was the nerve. And then once you've done posterior, you do lateral next. You can see the ureter is actually here. And this structure, which is tenting up here, is actually the nerve. And if you go lateral, you will damage this nerve, which will result in sexual and urinary dysfunction. So that's the ureter. That's the hypogastric nerve. And we stay close to the mesorectum again to prevent injury to these structures. You can see how the slinging of the uterus on top helps because the uterus is not falling into your specimen and you don't have to use another instrument to actually hold the uterus. This is the mesorectal fascia here. And you just stay on the mesorectal fascia and do circumferential reduction. So we did the left side. Now we're going to do the right side over here. And as you can see, the rectum is actually turning forward as we go deeper into the pelvis. And again, we stay close to the mesorectum rather than going towards the presacral fascia. And as we go deeper in the pelvis, the rectum moves forward. We should not dissect posteriorly because far away from the rectum, because then we run the risk of going into the presacral veins. We can see the pelvic floor coming up here, and the rectum is now being dissected off the pelvic floor. And if we keep going this, we can actually reach the intersphincteric plane as required. Like I said, now we have done posterior and lateral. We will do anterior last. And this is anterior. We go just above the peritoneal reflection, about a centimeter above the peritoneal reflection, and make the peritoneal cut. And then because we've done the lateral dissection, we again go from lateral to anterior and keep following the same plane. And if you keep following the same plane, again, the dissection becomes easier. And then we keep going down till we reach the pelvic floor. It's a nice bloodless plane. And as we go down, we can see that the mesorectum ends and the rectum becomes bare. And that really tells us that we are right at the end, very close to the pelvic floor. And so again,
how high was this tumor?
So this tumor, I think, was about maybe 6 centimeters above the anal verge, which would be about 2 or 3 centimeters above the PR sling. This is in the female patient. So we really went down right till the pelvic floor.
I think you have to get a good margin. Yeah.
So that's that dissection done. The next step, once we've done this, is mesorectal and rectal transaction. Mesorectal division should be ideally 2 centimeters below the tumor. We heard from Dr. Deep that even a 1 centimeter margin is okay. But if we can get a 2 centimeter margin, it's always good. Usually it's a staple division, ideally 1 load, but very low in the rectum. You usually end up using 2 reloads. We should try and avoid coning when we do the mesorectal transaction. And then finally, you can do a midline or a transverse incision and take the specimen out. It's good to use a wound protector because it just prevents wound infection. So we'll just have a look at this mesorectal transaction now. So we're doing a rectal examination there to confirm the position of the tumor. And then my instruments there to sort of guide where the end of the tumor is, and then sort of eyeball where 2 centimeters of distal to the tumor will be. Now that's where we have decided it will be. There's not much mesorectum left there in the lower rectum, but we make sure that we have only rectum and all the mesorectum is transected so that we staple only rectum and not mesorectum. So there's a little bit of mesorectum there, and we are dividing that mesorectum. This patient was post-radiation. You can see a little bit of this white saponification that usually is seen post-radiation in many patients. So the whole mesorectum is then sort of divided there. And finally, we have only rectum. Once we have only rectum all around, we confirm again that this is the point of transaction, and then we will staple with the help of a stapler. So again, it's important to look at 360 degrees, and then we use a stapling device, whichever is a stapling device of your preference or which is available to you. And then we go and staple. Now, it's very important to make sure that the stapler is fully open and it does not go through the rectum, but one jaw goes anterior and one jaw goes posterior. And then you fire. So here
you're using a green load as far as I can see. So
yes.
That means it's
yes. So for low rectum, yes, sir. For low rectum, especially in our population, we usually find the rectum is very thick and we use a green load.
Yeah.
Again, a little bit of the rectum is left behind. So we're using a second stapler. The importance of while using a second stapler is that we should try and put it distal to the first stapler line and not on the proximal staple line so that we don't have a hole in the sort of anastomosis. So that's the rectum transected. The next step will now be to look at the point where we transected the IMA and then complete the mesenteric division for the point of transaction. So you identify a point of transaction and cut the mesentery till that point. We can do an ICG test to look for vascularity. Now, if we are using an ICG system, we usually test the vascularity using ICG. Otherwise, you can just look at whether it's looking pink and bleeding on cutting it. So then the specimen comes out. You've got to have a look at the specimen and see what the quality of the mesorectal dissection is. These are some of our specimens. You can see this is a very low anterior section. And the mesorectal fascia is intact. There are no breaches in it. So this is a good quality mesorectal excision. On the left is a partial mesorectal excision for a sort of a higher tumor. You can see that the specimen is cut at right angles to the specimen. The mesorectum is cut at right angles and there is no coning. So these are good quality specimens, and it's always important as a surgeon to look at the quality of your mesorectal excision to see how you're doing.
Do your pathologists, when they report, tell the first line, quality of mesorectal excision?
Yes. So our pathologists do tell us, but I think it's very good for us to see ourselves because sometimes after formalin fixation,
good. but the standard is to have the pathologist, because that is what is used to analyze each surgeon's efficiency.
Yes. So yes, we do have it in a pathology report, and it's a good thing to use the standardized pathology form, which tells this. Once we've done this, the next is anastomosis and stoma. It's usually a stapled end-to-end anastomosis. We can use ICG to look for vascularity. We do an air leak test to look for any leaks. And then for low anterior sections, more often than not, we end up doing a loop ileostomy. So again, this is the video of the anastomosis. So you've seen the circular stapler has gone in through the anus. We are putting the anvil out. Usually support the rectum with a clamp so that it doesn't tear. The anvil has gone into the proximal end, and then we sort of dock. It's very important to make sure that the vagina does not come into the stapler in females. And once we have docked and tightened the stapler, we do a vaginal examination to make sure that does not happen. We are making sure that the lie of the colon is correct and it's not twisted. And as you can see, the mesentery is lying comfortably. The cut end of the mesentery is on one side and it's not twisted.
In this one, you did not mobilize the splenic flexion.
No. So we mobilize up to the splenic flexure, but not the splenic flexure. Here again, very carefully, you can see the vagina is completely out. The rectum is fully visible. And so therefore, there's no risk of rectovaginal fistula. The colon is also lying comfortably. It's very important to make sure that the length is enough so that there's no tension on the anastomosis. Then we're doing an air leak test. So we put some water and then insufflate air through a syringe in the rectum. You can see that the rectum is inflating, but no air bubbles are seen. So that's a negative leak test, which is very reassuring. So to summarize this, and then we can do a stoma. I've not shown the stoma, but for low anterior sections post-radiation, I usually will end up doing a stoma.
What
So
stoma? What stoma?
A loop ileostomy. Transverse
loop
colostomies, we've gone.
You do an ileostomy. Fine.
Yes,
Okay.
yes. So just to summarize this, I think if we are embarking on a low anterior resection, we can do it open laparoscopic or robotic, whatever skills are available, but it has to be done well. Very important is to select the patient properly, depending on tumor factors as well as patient factors. The preoperative preparation is vital to this operation, and you've got to sort of do the operation in your head, look at the imaging yourself, do a rectal examination, and plan the whole operation rather than just going there and doing it. It's not a simple, straightforward operation. You need to have the right equipment. You need to have the right positioning. Standardize your technique. Break down the operation in smaller steps. My advice to trainees is don't try to do all of these steps. Don't learn all of the steps of the operation in one go. Learn each step, then learn the next step, then learn the step, and then finally you will be able to do the whole operation. And then if you're doing laparoscopic, if there's no progression, there's no harm in converting. It's better to convert and get a good quality specimen than to sort of soldier on and get a bad quality specimen, which will lead to worse outcomes. That's all I have to say. I'm happy to take questions. Thank you.
So to put it into perspective, his last statement about conversion, there was a distinct relationship between the late conversion and the early conversion. If you converted late, you had very high local recurrence and bad results. But if you converted early, because it's a big tumor, you actually had as good results as you would have had with open surgery. So always convert early. So in our unit, if we are converting, it will be in the first 10 minutes. But once we have got, then we know that we'll be able to do it laparoscopically and we'll go on. But this early conversion is a very important thing, what he said. Don't wait till you've torn the rectum, till you've gone into the wrong planes to convert. That is bad.
Dr. Rohin? Yes, yes.
Yes, Utpal.
I have a few questions. Okay, Utpal first. No, Utpal, please.
Yes. Thank you, sir. Dr. Rohin, I have some questions. I'm a bit surprised that you have not done splenic flexor mobilization in this low anterior resection, because in my view, it is required in almost every cases in order to prevent that tension in anastomosis. So because this splenic flexor mobilization, I think, is most tricky on the part of laparoscopic LAR. So what is your take in that, in the splenic flexor mobilization in particularly in low anterior sections?
Absolutely. I think the most important point here is that the colon should lie comfortably in the pelvis without any tension. Now, patients some patients have very long redundant sigmoid colons, and the colon reaches very easily. There are patients who have very short sigmoid colons and it doesn't reach easily. So what we practice is splenic flexure mobilization when required. And splenic flexure mobilization also, we can do partial splenic flexure mobilization, or sometimes you require a full splenic flexure mobilization to get enough length. And so whatever is required. So in this patient, by cutting the peritoneum right up to the splenic flexure and then mobilizing the whole of the left colon right up to the the retromesenteric dissection up to the base of the pancreas, the colon reached. If the colon would have not reached, or if we had any doubt about the reach of the colon, we would have definitely done a full formal splenic flexure mobilization. So that is my take on this.
But students, for your exam, no anterior resection, splenic flexure has to be mobilized.
Yes, yes. Yeah, I think as a point, yes, you can say that.
Yes,
I would like to add about splenic flexure mobilization. When you see the patient, if the patient has a narrow costal margin, you will find that the splenic flexure goes very high. When the patient has a wide costal margin, you will actually find that the splenic flexure is easy to mobilize. And the way to do the splenic flexure mobilization is you come from the left and cut the fascia and mobilize the left colon. Then you go to the transverse colon and lift the momentum of the transverse colon and come. So you do what is called the omega maneuver. So you get both sides and then you will reach the apex and then you can mobilize it very safely and bring it down. Remember that splenic flexure mobilization is not what you're aiming for. What you're aiming for is to release the distal transverse colon from the pancreas by dividing the mesocolon that goes on to the pancreas. Once you do that, the distal transverse colon will move down and the whole colon will become straight. That is what you're aiming for. In this case, it was not needed. It was very obvious. It was lying smooth and in a curve. And in a Strendlman purse, if you had gone into the antitental bulb, it would probably be very, very lax the way it looked. So this didn't need, but when you do, you should see that in the antitental bulb where it become lax or not. And then, so you go and mobilize from both sides and take it from the base of the pancreas. And that is a very important step because that is what brings the distal transverse colon straight down. And then dividing the inferior mesenteric vein is not for oncological reasons. The inferior mesenteric vein acts as a bowstring. It bows the descending colon and sigmoid. So when you divide it, it straightens out the colon and gives you extra 3 to 4 centimeters, and that is sometimes very, very critical. I usually do a side-to-end anastomosis, trying to create like a small pouch. But if the length is not sufficient or anything, then I will do an end-to-end anastomosis. But I would say 80% of my anastomosis are side-to-end. And I find that that way I have a small pouch which is there. I don't know whether it does any benefit, but I believe that the vascularity of the side is better than the vascularity of the end. Therefore, I use the side of the colon for anastomosis. The important thing in anterior resection, in my opinion, which Rohin is following, which people don't follow, is to put the camera where he put it. Because they put it in the midline. Now you remember that the aorta is virtually a midline structure. To do the IMA dissection with the camera right on top of the IM is so difficult. I see people struggling. But here you saw, he was able to see the IMA very clearly. I have a slightly different policy. I don't take it at the base in patients who are diabetic for a long time, have chronic renal failure, and who have COPD, because they seem to have poor vessels. There I divide the IMA after the left colic is given, so that it acts as an extra blood supply to the colon. These are just some of the points I want to make.
Can I make a comment, sir?
Yes, Utpal, please.
Yes. So second question, Dr. Rohin, I think you have done tumor-specific that TME in this patients, and you have told that 2 centimeters is sufficient for that tumor-specific TME. But
No,
most
no,
of the
he has done a complete TME. I disagree. He has done a complete.
According
You could
to
see.
Dr. Rohin, according to Dr. Rohin, 2 centimeter partial TME is sufficient. But literature say that it is 4 centimeter. Should be at least 4 centimeter
He
TME
did say
should be done
no,
in
no,
case
no,
of.
no, no. You have
Dr. Rohin,
misinterpreted him. He did not say 2 centimeters TME. He said 2 centimeters bubble wall. There's difference.
Dr. Rohin,
Yes. So again, I think opinions are different over here. If you look at the classic Bill Heald paper, he's taken off all the mesorectum and given it
Your voice is breaking again.
we know now that no, please, that probably will help. So a 2 to 3 centimeter distal margin, even on the mesorectum, is enough. We do not need to go down on the mesorectum and take off all the mesorectum. That is my thought.
no, Dr. Rohin, this is true for example, it is a middle rectal tumor, and
Yes.
it is a 3 to 4 centimeter margin, and it is called tumor specific TME. So
Yes.
what you have done, it is tumor specific TME or complete TME in this case?
So this is a low rectal tumor. So here it is a complete TME. We have taken
That's
off
what I said.
everything.
He has taken everything off.
But if
And
it was
so for middle rectum and lower rectum, I also do a complete TME. And then I transect the rectum 2 centimeters below the tumor. But the TME is complete.
So I
You
have a
must-
few questions which I'm sure students have there in their minds. So first question is to Arun. Arun, what is the lowest level of anastomosis which can be done by staple, below which you would say it should be hand sewn?
Sir, again, depends on one surgeon's experience. To begin with, a stapled anastomosis will be something like a low anterior resection. Then, as his experience, the surgeon's experience advances, he can reach to ultra low anterior resection. That means at the level of anorectal junction. Then, with maybe some other years of experience, a partial ISR can be done with staplers.
No, what I wanted to know that below what level you would say that stapled anastomosis should not be done, it should be hand sewn.
Sir, anything below, if the level of anastomosis is below the dentate line, it should be hand sewn. That means a subtotal or total ISR.
But you said that the anorectal ring is at the level of the levator.
Yes.
Now, if I have mobilized the rectum up to the levator, the pelvic floor.
Okay.
Dentate line is below that.
Yes, sir. 2 centimeters
when I
below
fire
that.
a stapler, the stapler is going to be fired at the level of the pelvic floor.
Sir, that is for ultra low anterior resection, but we can do some amount of intersphincteric dissection into that plane between the levator ani on one side and external sphincter on the other side, and the smooth muscle of colon of the rectum on the other side.
The other question which is frequently asked from the students, and I think partly Rohin has answered that, but again, to give a specific answer, any one of you can take this, that upper rectal tumor, today, how much of mesorectum, how many centimeters below the lowest edge of the tumor you would take the mesorectum?
Me, 5 centimeters.
Utpal?
Yes, 5 centimeters.
Deep?
According to it.
5 centimeters.
5 centimeters.
So not a complete TME, which was originally described by Heald. Okay. Next is, how does the tumor histology, differentiation, mucin, whatever else, decide or dictate the margin?
In my opinion, if it is a very low tumor and you are thinking of doing an ISR or an APR, then I will do an APR if it's a poorly differentiated, if it's mucin secreting or sigma or mucinous adenocarcinoma. If any other tumor, I will use 2 centimeters rule.
No, so even for a well-differentiated tumor, no mucin producing cells, you would take 2 centimeter, or you would take 1?
I would try for 2 centimeters. But if I would try for 2 centimeters, if I can't, I may compromise on 1 centimeter.
That is what I'm asking. In order to preserve the sphincter in a well-differentiated,
I may compromise, but I won't compromise with any of the others.
That is what I'm
Even moderately differentiated, I won't compromise.
So, what about neoadjuvant treatment? How much minimum margin you would accept to preserve the sphincter if the patient has received neoadjuvant treatment?
Well differentiated, a negative margin, even 1 millimeter margin, but poorly differentiated, at least 1 centimeter margin, post neoadjuvant.
So what you are saying that if there is no neoadjuvant treatment for poorly differentiated 2 centimeter, with neoadjuvant 1 centimeter.
No, sir. With neoadjuvant, well differentiated, even a negative margin, 1 millimeter margin should be good enough to save the sphincter. But poorly differentiated, we need more margin even after neoadjuvant treatment because chance of local recurrence is high.
I would disagree. If it is well differentiated, even if you have given neoadjuvant, from the fresh margin of the tumor, I will take 1 centimeter. If it's poorly differentiated, I will take 1 centimeter.
Sir,
Because
yes.
No.
Because-
But please, just a minute. You are all talking of 1 millimeter. The moment you are firing
1
stapler-
centimeter, not 1 millimeter. I said 1 centimeter.
Arun said 1 millimeter.
He said 1 millimeter. I said 1 centimeter.
Sir, we aim for 1 centimeter, but oncologically, a negative margin is sufficient in a sphincter saving surgery post neoadjuvant.
Yes,
what
there's
I-
a paper. There's a paper from Britain which says a close shave anti-resection is
Don't go
sufficient.
by, please, Ramesh, don't go to individual articles. Tell what the student should say in the exam. This
1
session is not for
centimeter.
practicing surgeons. It is for
It's
students.
they should say that 1 centimeter should be the minimal margin that they should have after neoadjuvant, whether it's well differentiated or poorly differentiated.
Sir,
That
I
is what-
think today,
like
in
it.
today's time, patient who has received neoadjuvant treatment, favorable biology, any margin which is negative is acceptable. That is now very well documented, and there is a lot of literature available on that.
Sir,
But
sir,
obviously,
I am also saying the same thing.
I would like to ask you the question.
Sir.
You have a rectal cancer, and
Again,
your
again,
surgeon gives you
Let's
your
not
surgeon.
Ramesh,
No,
let's not go into that.
No,
Please,
No.
please.
They must
Talking
answer
about
this.
dumb, sir.
Will they
please,
accept a
Ramesh,
1
let us-
millimeter margin?
No. What you do in practice is a different thing. This is a teaching session. We have
So
to
in a
teach the
teaching
students
session-
what they should be saying.
See,
Don't go into individual
we
cases.
teach the student that you do what you would want done to yourself. That is what we teach the teacher, students. I think that's very important.
So once you are firing a stapler, anyway you are getting 3-4
Absolutely.
millimeter margin.
Yes.
Also,
There is no question of 1 millimeter.
Absolutely.
You are going to get, because
Yeah.
obviously you are
Yeah.
not going to fire it on the tumor.
absolutely.
So I think I haven't gone into the finer details, but I think what Deep is saying that good response to neoadjuvant treatment, well differentiated tumor. I read somewhere 5 millimeter, but it is definitely less than 1 centimeter. If you are aiming for, I mean, what Ramesh said is right. If you can get 2 centimeter, get 2 centimeter.
Absolutely.
If you are
Yeah.
not able to get 2 centimeter, even 5 millimeter, and as Arun said, even a clear margin is good enough. Once you are firing stapler, you will get 2-3 millimeter margin anyway.
Yes, sir.
So can I make
Ideally, we
Yes.
aim for 1 centimeter and more, but any negative margin is acceptable after neoadjuvant.
Absolutely.
See, this is, as a corollary, I would say when we teach students hepaticojejunosmy, we say get 2.5 centimeter stoma.
Yeah, stoma.
Now, if you don't have 2.5 centimeter, you can't get 2.5. So you get whatever best you can get.
Sir, one comment regarding a negative margin in double stapled anastomosis.
Yes.
The proximal donut is a complete donut which circumferences the entire circumference, whereas the distal donut is only representing a center or a part of it. So a negative distal donut doesn't give anything. The negative margin should be in the specimen itself.
proximal?
That's absolutely true. The donut is
Yeah.
of no use. If the donut shows positive, it is of some importance. If it shows negative, it means nothing.
So can I make a comment?
Yes, please.
Just for the technical reason, sometimes you struggle firing a stapler in a narrow pelvis. The trick at that point of time probably is to use a smaller stapler rather than using a 6 centimeter stapler, and use probably 3 rather than 2 stapler. Also, sometimes problem is of angulation, that on the right side you are higher and on the left side you are lower. So there you probably need to fire half a stapler on the right side and then adjust your margin. And somebody from the below should be guiding you with the finger that you are almost, becoming transverse with subsequent staplers. That was one.
There is an alternative to this.
Sir,
The alternative is you divide the specimen on the upper end, then you tie a good, strong umbilical cotton tape at the upper end. Then you push a long Kelly's clamp and you through the anus and you puncture near the upper margin of the specimen. Catch this strongly tied umbilical cotton tape and pull the rectum, everting it out of the anus.
sir,
You
I
will
would
see
not
the
be
mucosa.
a hole in the
You will see the mucosa and you can divide with a stapler very comfortably under vision. I have done this on about 5 occasions and they were very difficult to do from above and so easy to do from below. Then I just pushed it in and then put the double stapling technique. You can try it. It's a very good technique.
One more, although that was not the topic, but since the experts are here, which is frequently asked of the students in the exam, you have given short course neoadjuvant radiotherapy. Conventionally, we used to say operate within 7 to 10 days, but now there is evidence that waiting longer. So again, what should the students say that suppose the patient is suitable for short course neoadjuvant radiotherapy, that means it's not a bulky tumor. How long should they wait? And if you are waiting for a longer time, do you add chemotherapy in that?
You
So,
only wait if you are planning to do TNT, as you very rightly said. Otherwise, you still operate within a week.
No,
You're giving short.
I strongly disagree. I think I am the person who has been the strongest proponent of short course radiotherapy for over 25 years. I have been using it for 25 years. And I used to operate it within 1 week, within 5 days, the next Monday after the radiation, like that. But over the last 10 years, we now have sufficient evidence that you must wait for 8 to 10 weeks. What happens, Vinay? And you will not believe this. We have enough cases documented now in our center that if you wait 8 to 10 weeks, the effect of a short course radiation is equivalent to the effect of a long course radiation, and we get almost a complete response.
So do you give chemotherapy?
Yes, we give 2 to 3 cycles of chemotherapy in the intervening.
So that's what I'm saying. If you want to give chemotherapy, then wait. If you don't want to give chemotherapy, then
even if I don't, but I will always wait. Whether I give chemotherapy or not, I will not operate because the tumor will shrink up to 8 to 10 weeks. And if it's a bulky tumor, that's what you want. You want it to shrink. People say that bulky tumors don't shrink with short course RT. They are wrong. The
Rohin,
evidence now is that it does shrink.
Conventional thing is short course followed by operation after a week. But as per the new protocol, which is the Rapido trial protocol, we give short course, then we wait for 10 weeks, but we give chemotherapy during this 10 weeks.
Absolutely.
And what we found in the Rapido protocol is that complete response rates are up to 30 to 35%, and there are better short-term outcomes. However, there's a caveat. The long-term results have just been published, and there's a higher systemic
local recurrence and systemic failure.
Local and systemic recurrence with the Rapido protocol.
Absolutely.
So the Rapido protocol was very famous during COVID, where we gave short course chemotherapy, RT chemotherapy, waited for 10 weeks and then operated. It seemed to have better short-term results, but the caveat is that there might be worse.
That is not completely proved. It is not a statistically significant difference. You know that. It's a mild difference, but not statistically significant.
It is significant, sir. It is statistically significant.
No, it is not significant.
Especially distant failure, sir.
Okay, distant failures. That is why post this, you must continue the chemotherapy. So you must continue. And the short course chemotherapy, which we give now, is FOLFOX. They were giving capecitabine in the Rapido trial. We are now giving FOLFOX. So our protocol is short course radiotherapy, FOLFOX, 3 cycles, and then operate 8 weeks.
The other question is, how do you decide whether you would give short course or long course chemoradiotherapy? How do you
my decision on my patients is always short course radiotherapy followed by chemotherapy. I do not believe in the long course radiotherapy.
Deep, how do you decide what to do?
A patient where the indication of neoadjuvant treatment is...
You're cut off.
we lost.
We
Rohin,
lost-
what is your
Yes.
practice? How
So,
do you decide?
so when the CRM is involved and we want to downstage and make the CRM negative, we would give long course and then wait for 10 weeks for the CRM to become negative. If our aim is to reduce local recurrence because the tumor is T3 or node positive or has EMVI, but the CRM is not positive, then we can give short course. That is what students should answer, I think. There are many caveats to it, but this is a answer for the exam.
Arun,
Our unit follows only conventional long course chemoradiation.
for all cases?
All cases, sir. Any T3N1.
But I think that there is enough evidence now, especially King George Medical College has published a paper where they have shown that short course radiotherapy is very effective. And for a poor country like ours, where patients come from long distance for chemotherapy, for radiotherapy, 5 days of radiotherapy is far more friendly to their pockets and to their relatives than 6 weeks of
I
radiotherapy.
think what Rohin said is very important for students to know. If it is a bulky tumor, you want to reduce the size, downsizing, then most people would give long course chemoradiotherapy.
They give long course because they follow the NCCN
Then you
guidelines.
want to sterilize the margin to reduce local recurrence, where technically the tumor is upfront resectable. Most people would give short course. Whether
No,
you wait
Vinay,
for,
you're wrong.
whether
You're
you
wrong.
wait for short time or
No,
long
Vinay,
time.
this is
Sir,
the
I have
North
joined back.
American.
Sorry. Can I
So,
I have joined back. Sorry.
1 second. Vinay, this is the NCCN guidelines. But when you look at the ESMO guidelines, they give short course for everybody, including bulky tumors. Because once you wait for 8 to 10 weeks, even the short course radiotherapy reduces the tumor size. The belief is that long course is more effective. But what happens is that because you've given a high dose in a short time, the effectiveness at 10 weeks is equivalent in
But
both.
still long course chemoradiotherapy is being used. It is not out of the.
No, it is still being used. That's what I'm saying. But ESMO.
That is what I wanted to know. In which case you would give long course.
I would give, even to downstage the tumor, I would give short course. That's what I would say.
That is what you are saying. You
and-
are saying
and
there
I'm
is no
following-
place. You are
and
saying
I'm
there is no
following-
place for long course chemoradiotherapy. That is what you are saying.
I'm saying that I don't believe there's a place. I follow the ESMO guidelines.
Don't say what you do. Say what is
I
recommended.
say I am following ESMO guidelines. That's what I said. European Society of
So-
Medical Oncology.
So
guidelines.
ESMO says there is no place for long course chemoradiotherapy.
No, yeah, most of them, they don't give long course.
Okay. Deep.
The
No,
reason
sir.
is,
In our practice, short course I will use in a patients where tumor is not bulky. I just want to sterilize my margin. If there's a bulky tumor, I want to downsize, downstage, long course radiation. There is no debate about it, sir.
Okay. I
that's
think
what I'm
we
saying. There is no debate depending on what is your point of view. You follow the NCCN guidelines, you do long course. You follow the ESMO guidelines, you give short course. But in a resource-intensive country like ours, where we don't have the resources, I think short course should be used in more and more patients so that we can relieve the radiation.
Sir, there is no
units.
evidence at this point of time to suggest that short course is equally effective in downstaging or downsizing.
There is
It is not,
evidence.
sir.
I am sorry, the Stockholm 3 trial, the Polish 3 trial, the German 3 trial, I'm giving you 3, and the Amsterdam 3 trial, I'm giving you 4 trials. Please read.
I will
Please
read,
go
sir,
and
and come back.
I have read. That's why I'm saying.
We are at 8:59. As I said that we start at 7, we close at 9. So I would like to end by
No, but
thanking.
the students, if they have any questions, you can just finish.
No, those questions have already been addressed on, because they are
Okay.
not on this portal. They are on WhatsApp chat,
Okay.
YouTube chat. So I would like to thank the moderators, Ramesh and Utpal, and the speakers, Arun, Deep, and
Rohin.
and as I said, posted in the chat that yesterday's session already has had 400 plus views. We have very few live students joining because they have the option of watching these videos later. So I don't mind the number. We had about 25 live students, but I'm sure by tomorrow morning or tomorrow evening, we'll have almost same number of views. Some of our previous master classes are now touching almost 1,000 views. So all the 14 master classes have been posted. So students who are watching it on YouTube, please watch the previous master class videos. All the JST videos are online at the Gastro University website. All the Jaipur Surgical Festival presentations are on the same portal. This is a portal which is provided to us by Dr. Avinash Nath. And if you want to read a little more about CA Rectum, please send me a mail, as I have projected in between, vkkapoor.india@gmail.com. Just write rectum in the subject of the mail.
Vinay, I want to congratulate you for doing this academic exercise, bringing such experts like Deep, Rohin, and Arun on the forum, and having a differences of opinion so the audience sees that there are multiple ways to manage the patients. I congratulate you for this. It's a very difficult job to do, to organize it regularly and to bring people and to get them to speak. Really wonderful achievement on your.
Thank you. Thank you very much. Thank you, everyone. Good night.
Thank you so much, sir. Thank you.
Thank you,
Good
sir.
night.
Thank
Good
you, sir.
night. Good night.
Good night. Good night.